But clearly, why don't we start earlier and go by disease trajectory? Let's start with the so-called localized setting. We saw data in the so-called high risk, localized with ENZARAD, and then we also saw data for biochemical recurrence, an update of enzalutamide in that space. So Chris, why don't you take us through those?
Absolutely. I think the general trajectory in oncology is always to establish the drug in the later disease phases and then try and test it earlier on. And ENZARAD is the natural continuation of, I think, our current understanding of using ARPIs in prostate cancer. So to lay it out, ENZARAD enrolled NCCN high-risk patients. So that's clinical 3, high-grade histology, Gleason 8, 9, or 10. Our PSAs over 20. That contrasts a little bit with STAMPEDE, which was an enriched, very high-risk population, i.e. clinical node positive, or 2 out of the 3 of PSAs over 40, Gleason score 8, 9, 10, and clinical stage T3. So this is a NCCN high-risk population, but a little less high-risk than STAMPEDE. And in the context of ENZARAD, patients were randomized to either a control arm that included radiotherapy in very modern and appropriate doses and delivery approaches, and 2 years of ADT, and then the intervention arm got that as well as the addition of enzalutamide. And I think it's important to note, back to the demographics, to understand that this cohort included about 10% clinical node positivity, in contrast to STAMPEDE, around 40% clinical node positivity. So we are looking at a high-risk patient population in the localized disease setting, but a little less high risk than the data we've seen before. As we move forward, we're looking at a primary endpoint of MFS. That's the appropriate thing, I think, in this context. IceCap shows us surrogacy. So if we can improve MFS, we are almost certainly improving OS. Unfortunately, in this trial, we don't improve MFS. We have a hazard ratio of 0.88. We have, at baseline, just really good outcomes, I think, for our patients in the control arm.